go to Epicenter Projects, and then look for Project Red Talon. Once you click on that, it'll be right on the top. And going through that, it seems like that was a lot of information just to give to get PowerPoint out to you. But that is where it is if you'd like to see it. So then starting out with our project, the name of our project that we started is the Quality Improvement Project, and we lovingly call it QIP. QIP was a year-long project that focused on quality improvement in 4 separate Indian Health Service and or tribal health facilities. We started off with 5. We ended up with 4. And the aim of the Quality Improvement Project was to promote sexual health and wellness for American Indian and Alaska Native people. QIP worked with healthcare teams in order to improve access to and the quality and standard delivery of sexual health services, including screening for chlamydia and gonorrhea, HIV, and viral hepatitis. Also, other sexual health quality of care measures were thrown in there as well. And the QIP project really wanted to strengthen positive relationships between healthcare systems and care teams by focusing on like the whole gamut, by focusing on prevention, screening, and treatment of sexually transmitted infections. The goal of QIP, as it ended up being, everybody adopting at least 2 measures. And those measures were chlamydia screening for sexually active women between the ages of 16 and 25, and HIV screening for everyone between the ages of 13 and 64 at least once in their lifetime. So based on CDC and Preventative Service Task Force recommendations. Now, along with those 2 measures, at least one facility also adopted a measure of hepatitis C testing for persons born between 1945 and 65. So again, the new measure that came out. And that's a facility that had been previously screening for chlamydia and HIV. A caveat of being a goal of QIP was that all of those measures had reminders built into the electronic health record system. So those reminders might not have been turned on at all of the facilities at the start of our project, but the ability to have that EHR reminder was there for everybody. And so Donald Berwick, IHI, Institute for Healthcare Improvement President and CEO, has this really great quote. And it's that every system is perfectly designed to get the results that it gets. So when you're looking at screening rates, no matter where, really, unless you have like the super stellar awesome facility, they're low. So National Chlamydia Coalition put together this list of commercial HMOs and PPOs and Medicaid measures based on the HEDIS measure, the screening for chlamydia for women between the ages of 16 and 25. And, you know, it's between 40 and 61% or something. So low to kind of getting high, but still low, like when you're talking about sexually active females based on the recommendation. Well, IHS compared to that is at about 32% screening rate. So it's even lower than those. And then if you're looking at HIV screening rates, the VA has put out there that their screening rate, it was at about 20%, but that was a year ago. And I know that it's increased since then because they have done a push for HIV screening. And then Kaiser did a survey. Now this was a focus group survey, so it was like a qualitative survey. It's not based on medical records. But they did do a survey of folks, and they had a screening rate for HIV ever screened at about 52%, so relatively high. It's a pretty high rate, although that's self-disclosed. And then compared to that, IHS is at about 32%, which is a lot higher than it has been in the past. We've really increased both of those measures actually significantly since our big push over the last 2 years. So, I mean, no need to kind of like talk to you about how STDs are this major public health challenge in the United States, but when you're talking about American Indian Alaska Native people, they definitely have disproportionately higher rates. AIAN people have the second highest rates of chlamydia and gonorrhea. Chlamydia is like 2 times higher almost based compared to non-native whites.
Right.
And there's been this like increase in gonorrhea throughout Indian country over the past year.
Yeah, with Michael Green et al. That's why.
I'm just going to stop talking until that ends.
Please mute your line.
You know, so like, although I'm not talking about it today, these disparities are obviously complex. They're rooted in a number of social factors. There's poverty, inadequate access to health care, education, lack of education, and then social inequities and cultural influences. But when you're seeing such high rates of chlamydia in Indian country, you know, you might expect to see higher rates of screening, but you don't see that. And perhaps there should even be a higher rate of screening because of the high rates of chlamydia in Indian country, but you don't see that. And so this project really wanted to start working on that issue. Bill Gates had a great quote. When you start looking at a problem and it seems really simple, that just means that you don't really understand the complexity of what the problem is. And then when you get into the problem and you see that it's really complicated, you come up with kind of crazy convoluted solutions. And that's sort of like the middle ground and where most people stop. They don't push through. But the really great person is going to find the key and the underlying principle of the problem and come up with a really elegant, very beautiful solution that works. And that was our goal, really. You know, yes, we wanted to increase screening in Indian country, but we wanted to create a solution for the problem. And this in and of itself, that quote that I kind of butchered but kept the essence, was really the method of our project. You know, not a traditional methods, but a process and methods of how we as a group looked at the problem of screening in Indian country. It's how we dissected that problem in order to really understand what was going on so that we could address it and ultimately like solution it. What we came up with was that so often the only thing that matters is the metrics, are the end products of how many people did you screen, how many HIV tests did you run, how many people did you get in for follow-up. And although those metrics are very important, we were focusing on something completely different. We were going to focus on engagement, and the idea that engagement is greater than adoption, is greater than usage, and is greater than metrics. Because although we definitely wanted to see our numbers going up, you know, we wanted to do good and we wanted to have those good results, we also wanted to bring joy and engagement into the project. So in order to do that, we really needed to kind of shift the focus of the traditional project and what it looked at. And so by focusing on engagement, like what does that mean? We were focused on relationships between project leads at the sites and the project, you know, quote unquote officers. The project was very communication driven. So by relationship and communication driven, whenever possible, especially in the beginning, to form those relationships and connections between people, we had Adobe Connect sessions whenever we could, and used video conferencing on Adobe Connect whenever we could. Because even if it was just me on the video call, at least I was able to like be a human being to other people that were participating in the project with us. I wasn't just letters on an email chain, and I wasn't just a voice on a phone. They knew I was like a real person. We were also super in the beginning trying to work with getting everybody on Facebook and Twitter and making games out of things, like sending each other pictures, just to really solidify that engagement and that connection between human beings and the project. We wanted to focus on the fact that this project was purposeful, that the ideas behind it were valued, and that we were very creative and adaptive, so that people had value in the work that they were doing, not just the production of numbers, and that people were able to use their own creative strengths to kind of solidify the project at their site. And so then after the engagement, which had to be present, we worked on adoption. We worked on the adoption of those two measures, chlamydia screening for sexually active women, and then HIV screening once in a lifetime. And then further, like when we were working on adoption, we asked like 3 questions. We asked more than 3 questions, but the 3 questions that were kind of core were, what is the perceived benefit of the study, both to you as a person and also to your facility? What is the perceived compatibility of the study? And then what's the perceived complexity of the study? And we did that because each site was very different. Each site was different regarding where they were and then where they were going. Each site was going to be able to go forward with the project based on the different strengths of the project leads at that site. We had 4 different strategies that we then focused on as far as usage of actually like utilizing a project lead's strengths to move forward with the project. So one was engaging the community and leadership. It was like getting outside of your office and talking to your clinic, talking to your physicians, to your nurses, to your CNAs, talking to the people who are coming inside of your clinic, and then also to the tribe that you're working with. 2, developing and sustaining a healthy and successful workforce. So, and by that strategy within there was like, well, do people even know about CDC recommendations? How are they supposed to screen when they don't know that they're supposed to screen? Do they fully have the capabilities to utilize EHR? If they don't, then each site needs to be trained on how to use reminders in EHR. Because only when you have happy people are you going to have like productive work. And then 3, developing policy and procedures. At a lot of places, they have policy and or procedures that were developed in 1993 and that hadn't been updated since then. And then lastly, optimization of clinical information systems. So having electronic health records turned on and working properly for each site. And so with all of that, once you had like the vision, the skills, incentives, the resources, and the action plan to move forward, was when we were able to see change happening in a lot of those sites. And at that point, and only when you came to that point, were you able to look at the metrics of the site and what their data was. Because like, the data is important. If you don't know your own data, then you don't really care. You can't care about what you're doing because you can't see the progress that you're making. So from the very beginning, although metrics was last and data was last, it was always spoken that it was super important. We had bi-monthly reminders on the calendar system for data. And the super cool thing to me is that we saw improvement. Now, just prefaced with the fact that all of the data are preliminary data, but if you do have the graph in front of you, then you can see improvement. And if you don't, take my word for it, please. That across HIV, chlamydia, and hepatitis C for all clinics, even though all clinics didn't have hepatitis C turned on, we saw a lot of improvement. The top clinic for HIV screening ever is at 72%, and although they did start higher because they had been doing it longer, they lead IHS now in screening for HIV ever. And then the top for chlamydia screening rate is at 73%. They came from a base score of 2%. So before the project, their screening was at 2% for chlamydia, sexually active women, and at the end of the project, it was 73%. So those are just some of the numbers that I wanted to point out. There's a lot of other information that we're going to have to look at, and that you can look at if you have the slides in front of you. And some of the data we definitely have to look more at because we're not able to. Some of the facilities are still just having some problems, getting their data out and giving it to me in a format that we can kind of look at throughout the 4 clinics and compare across the 4 clinics. But overall, we definitely saw improvement, a lot of improvement, and I think that it was a really good indication of what you can do a really good product of what you can do when you reimagine what a healthcare project should look like or could look like when you're talking about increasing screening or something like that. Because what it's all about, getting back to what we wanted to get back to was what healthcare was all about, and that is that it can be fun and joyful process while you're doing really, really excellent work. So with that was just a project overview, and I'd like to now turn the phone over to Dr. Mera, who was one of our sites in the QIP project.
Okay, thank you. Good afternoon, everybody. I hope everybody has, or most of you have the slides, so you can follow me. And I'll mention when I'm switching slides so it doesn't get too confusing. So as was mentioned, I direct the infectious disease program here at Cherokee Nation. I've been doing infectious diseases for many years, but this is the first time that I take the prime responsibility for a screening project. I mean, I've always been in favor of screening, as an ID physician would be, but this is the first time that I organize and try to move the project forward. And as Jessica mentioned, I think I'm still in the stage of convoluted solutions, but I think I'm moving on quickly. So the next slide, it's just the outline, and I'll show you what the care delivery structure of Cherokee Nation looks like, what steps we took in the screening process, some problems and solutions we came up with, some more problems and other solutions, and then some conclusions. So the next slide is just to give you an idea of the volume of patients that we have to deal with screening. And I want to stop here for a second and explain that when I looked at screening our population, I was not only looking at the rates of people screened when they come into the facility, but as the population as a whole. Because when the two objectives, or there's the two main objectives of screening is to detect the disease and treat it, and in infectious diseases also to avoid transmission. But to avoid transmission, you have to have a critical amount of patients screened and treated before that transmission can start decreasing. That's why I just wanted not to think we were very successful in some clinics because our screening rates were high, but the overall population screening rates were low. So having said that, so in Cherokee Nation, we have 299,862 enrolled members. 174,000 of them accessed our system in one way, form, or other in the 12 months before we started our screening project. 70% of them do it through our only hospital, which is Hastings Hospital in Tahlequah, and 30% of the visits occur in the outlying clinics, which we have 8 outlying clinics. The next slide, you will see more numbers, detailed numbers of the amount of patients, the number of patients that came to each clinic and hospital in the previous year. And what we found out is that 70% of the patients come through the central hospital. This is not the ideal situation, but it is the reality. So 70% of the eligible patients for chlamydia screening and 71.3% of the eligible patients for HIV screening came through the central hospital. When I mean say eligible, I'm going by the definitions that Jessica just mentioned of who should be screened. So of the almost 300,000 enrolled members, 170,000 came to our facilities and 70% came through the central hospitals. When you go to the next slide, which the title is Care Delivery Structure, I divided it into the 8 outlying clinics and Hastings Hospital. The reason I did this is because when a patient hits the medical system, it can do it through different doors. If you set up your screening process in one door, you will be missing the other doors. It is much easier to screen in the outlying clinics since the ingress of patients is basically through a medical service, through a dental service, or through the diabetes program. But when you look at the hospital and you see a list of services, they can come through many places. They can come through surgery clinic or to the dental clinic or pharmacy just to pick up a prescription that was given in an outlying clinic, etc. So it's a little bit more difficult to screen everybody when you're doing it in a hospital. But anyways, what we decided to do is to target in red, you will see 6 services, and in bold and italics were the 4 services that we initially that we ended up implementing our screening process, which basically was the Well Women's Clinic, Adult Medicine, the Residence Clinic, and Pediatrics. On the next slide, I'll show you what steps we took. And before going there, the slide which title is Barriers to HIV Screening. Before we started to design what we were going to do, we kind of looked at the literature and saw what were the barriers for screening, specifically for HIV. But it is applicable to most of our screening targets. And there are knowledge barriers and there are system barriers. We kind of went over them, physician awareness and perception, public awareness and perception, legal misconceptions. Some people think that you can't screen without filling out certain paperwork or obtaining certain permissions, cost effectiveness misconceptions, linkage to care, which is very important. Many physicians will say, well, why would I screen this patient for, let's say, hepatitis C? When I get a result, I don't have where to send them. And that's one of the reasons that we only did HIV and chlamydia initially. We're doing Hep C now, but we wanted to make sure that if a provider detected a positive patient, they had a means of doing something for that patient. And then there's system barriers, policy barriers that Jessica mentioned, workflow barriers, and electronic health record barriers, or paper barriers. Not all our clinics. Most of our system is it's an EHR, but some areas within the system still work with paper. So when you go to the next slide, steps in the screening process. Well, our goal was to increase the screening rate from our baseline by 10% during this first year. And as baseline measurements, the denominator was any patient that's eligible for screening that accessed the hospital in the preceding 12 months. Numerator was the patients who were actually screened that met eligibility criteria. We started at Hastings Hospital just to make sure our process was working decently, I would say, and then we expanded it to the outlying clinics. To address the knowledge barriers, we held lectures, 2 general lectures in the hospital with nurses and medical providers, and then we went to each site that we were going to implement screening and had a one-to-one conversation with the nurses, with the physicians, and I did it myself, and I went with the IT personnel to help them go through the EHR and exactly know how to work the reminder and how to set up the screening orders. To address system barriers, we basically thought initially that the EHR was the only problem, and or potential problem, and we focused on how they could remind themselves that someone needed screening and then implement the orders. So on your next slide, you'll see what our screening baseline was. And this baseline is taking the whole population, the whole Cherokee Nation population that came in contact with our system the year prior to our screening program. So in HIV, out of 82,000 patients, only 2.9% had had an HIV serology done. And on the chlamydia, out of 11,000 eligible females, only 2,700 had it, which was 23% baseline screening, which was pretty pathetic. The next slide shows after we implemented what I just mentioned, the lectures, training the nurses, the physicians, etc., 8 weeks after that, we measured it, and we saw that we were not going anywhere too fast. Our screening rates were barely getting elevated. Adult medicine was doing a little bit better, but the rest of the clinic were kind of not moving fast. So we went back and see where were the problems. And on the next slide, that's titled Initial Problems and Solution. So there were several. We divided the problems, general problems, and certain services like pediatrics and urgent care and emergency department. So the first problem was staff. Many staff did not know when the patient was due for screening. And remember, providers have 15 minutes to see a patient. And if they're seeing a patient for any medical problem not related to screening, they do not have the time or do not want to waste the time on screening. So the solution for that was we revived the reminder and we asked the nurse that was rooming the patient in to trigger that order for the EHR. Now, we found out there was a policy that did not allow nurses to place standing orders for these type of studies. So we changed the policy. It's easy to say. It took us about 4 or 5 weeks until we talked to all the leadership and got it approved through the channels that are implemented in our hospital. But we had a policy that empowered the nurses to order the screening test, and the physician would just have to sign off at the end of the day that the screening was ordered by the nurse. Other areas that there was not enough time to counsel patients about the screening, so we kind of reinforced the concept that the general informed consent that the patient signs at registration when they come to get health care is enough to cover for screening. And we got the advice of our lawyers, and they said that was good enough for legally allowing us to screen a patient. And of course, we try to tell the nurses, explain what we're doing, and it's an opt-out screening, and that was done in most of the cases, I believe. Pediatrics was a problem. The screening rates were the worst, and basically they did not want to deal not so much with the kids, but with the parents. So we did print some brochures tailored for adolescents, and in those brochures we stated the Oklahoma laws addressing that minors can be tested, screened, and treated for STDs without parental consent, thinking that might solve some of the problems. Urgent care and emergency department were a nightmare. Basically, you can see it in the quotes there. This is crazy. Why should we screen in the ER? We are too busy dealing with important things. So our solution for that is we just left them out of the screening process initially. We're having too many headaches at that time to deal with them. And we would come back. So on the next slide, a few months later, we had 2 sad cases of patients with AIDS who presented in the emergency department. And they had been through our system, and specifically the emergency department, one of them I remember 7 times in the last 3 or 4 months, and never had an HIV screen. So that kind of brought up their attention that maybe they should be screening patients. And then when we looked at the numbers of patients coming in the hospital, many patients never see a primary care provider. They just come through the ER or through the urgent care. So we met with the medical director, obtained support in the screening process again, and they encouraged the ED to start screening. Although the process was not established formally, I think at their conscious level, many of the providers thought that screening wasn't such a bad idea after all. We also expanded the screening to the outlying clinics, the 8 clinics I've mentioned, because many patients came to our ER but were not being seen by our primary care providers. And that way we can at least hit them, screen them in the peripheral clinics if they went there. So on the next slide, you can see what was the impact of engaging the leadership of the ER, urgent care, and of the hospital in the screening rates in the emergency department. And the 2 AIDS cases that presented were in November and late December. And you can see that our screening rates, this is number of patients, this is not percentages, I'm sorry. The number of patients that were screened in those months for HIV in the emergency department almost was 4 to 5 times higher than before. So that had a fairly good impact in screening in those 2 departments. So in the next few slides, I just want to show you, just for you to get an overall picture, that our screening rates in the peripheral clinics, these are the 8 peripheral clinics. The blue is the baseline, the red is as of July of this year. Most of the clinics had an increase, fairly good increase in screening rates, but don't get fooled by the numbers. The fact that some clinics are screening 50 to 60%, that does not mean that the target population has that level of screening, because many people don't come, or they come through the system through different areas, not through where we set up the screening process. And when we look at HIV, this exemplifies a little bit better. You can see, for example, women's clinics have a very high of HIV screening, basically because that's part of their workflow, and that's a critical point. If you don't make screening part of your workflow, it will not work. Residence clinic had a very nice and interesting rise, and I think that was probably due to continuous education. They're younger, they are eager to learn and adopt new processes, and probably many other causes that are out of my reach right now. Pediatrics, it's a catastrophe for many reasons. First, they think that they don't see AIDS patients, and of course they don't, because we see them as adult when they hit the adult area, even if they get infected as a teenager. And there are other issues in the pediatric system that make it a little bit more complicated. So you can see that women's clinic and residence clinics have very high screening, but when you look at Hastings Hospital overall, the increase in screening is not that impressive. For chlamydia, if you look at the percentage rates in the outlying clinics, we have a fairly good increase in most of them, a very high increase in one of them, Vanita, and that was because the medical director was extremely engaged in the process and had a lot of influence over the medical providers and the nurses. And that's a critical thing to have when you're trying to do anything in medicine. On the next slide, you'll see chlamydia screening at our hospital, and also adult medicine resident clinic had a high increase. Still, you can see that although they're screening at a 60–70% level, when you look at the hospital overall, we're screening at a 20% level. That's because many of the females don't come through those clinics. So in summary of the data, after 1 year, we did achieve at least a 10% increase in HIV screening. Before we started, only 2,300 patients had been screened out of 84,000 or so. In 1 year, we screened over 11,000 new patients for HIV, which puts us at 15% of screening rates, which doesn't sound that great, but that's the best we could do. Chlamydia was worse. We went from 23 to 26% because it's much more difficult to obtain, to have these young females, which are otherwise healthy, come on a yearly basis to get health care. So my conclusions from our process are the following. Effective screening programs need a multi-pronged approach to be successful. Have in mind that especially in the case of HIV and possibly chlamydia, where screening and treatment not only have the goal of avoiding complications of the disease in those individuals, but has the goal of decreasing transmission in the community, you need to measure your target population as a whole, and not only be happy because your women's clinic is screening 80% of people, because that does not really represent the reality of the whole population. Engaging leaders, physicians, and nurses is critical. My experience, nurses are the most leaders are important at the beginning to send out the message that screening or whatever you want to do is important, but the nurses are critical through the whole process because they are the ones who are ordering the tests. Don't rely on the providers. They're too busy doing other things. If policies interfere with the screening, you have to change the policy. And in our case, we did have policies that did interfere, and we changed them. If not, you're not going to be able to go over that hurdle. Education is critical, not only with with providers, but also with patients. We have not done enough work on community education yet. It is our plan to do it this year. But even if you do both, it is not enough, because you can have providers that have bought into the screening very well, but because they forget or because the system does not allow them to do the screening in a timely, fast, and easy way, they just won't do it. So screening by primary care is essential, but not enough. You have to incorporate all the sites of patient access into your system. If it's a hospital, you have to screen everywhere you can. If you could screen in the cafeteria, I would do it. But our plan for next year is to incorporate all those other services, including orthopedics, dental, even pharmacy, to start offering screening. So screening needs to be part of the workflow, and I think that's one of the critical messages, at least from our experience. If it's not part of the workflow, it won't be sustainable. And the best example is how screening for HIV and chlamydia works so well in the Well Women's Clinic or obstetrician's clinic, where it's incorporated into their workflow. EHR reminders are critical, are very important, but they only work if you turn the computer on and if you look for the reminder. So although it sounds ridiculous, it's very true. And many of the computers are on, but the people are not looking for the reminders. If you have a system that helps you pop out the reminder without you having to look for it, probably it will work better. And finally, screening patients who come to care is half the job. 0.5% of our population that meet eligibility screening criteria do not access the healthcare system. So strategies to reach out to the community are needed, especially if you're trying to avoid transmission of a disease. And in our particular case of Native American populations, just to remind you, we only serve and can treat Native Americans. And Native Americans have partners that are not Native Americans. So some policies need to be changed, and collaboration in the screening process with the local health department, I think it's critical. And I have one phrase that I like very much: not everything that is faced and can be changed, but nothing can be changed until it is faced. Well, thank you.
Thank you, Dr. Mera, and thank you, Jessica. I think that your talk was just really encouraging to all of us who are thinking about this work and doing this work. And your screening increases are definitely noteworthy. I think they're really unbelievable. At this time, I am going to open up the lines. I had to mute the lines.
The conference has been unmuted. The conference has been unmuted.
And if anyone has any questions, comments for Jessica or Dr. Mera, please jump in at this time. *6 to unmute if you have it on your phone. All right, *7. Questions, comments? So I have one to just start folks off. When you started thinking, and I think, Jessica, you yourself used the term joy, which when I hear joy, sometimes I don't always think about it in the work that we do. What really started this whole engagement piece when you started thinking about it from that aspect?
I mean, honestly, where that all came from was two things. One, a presentation that I saw last year at the Improvement Healthcare Initiative conference in Orlando, and they had this picture of, I don't know if it was like a llama or an emu or something like that, and they were talking about bringing happiness and engagement back to work. And I got to thinking, you know, like, I'm very lucky in that I love my job. I am so lucky that I absolutely love the work that I'm doing every day. And then I started thinking about how it must, you know, just like suck for people who don't enjoy their job. And like, how could you possibly do a good job if you don't enjoy what you're doing? And I started asking the question when I would go out to clinics and to do presentations, like I would ask the question, like, why did you start doing what you're doing? Like, why are you doing what you're doing right now? And like hopefully to get back to like the very beginning of why anybody gets into healthcare, like crossing my fingers, you know, and especially if it's my physician, they got into healthcare because they want to help people. You know, they want to help a human being be healthy. And so that's kind of where that all came from. It's just like how can you then, if you aren't happy in your work right now, like to ask people the question, like how can they get happy?
And part of that was making sure that they had adequate tools and resources to do their job.
Definitely. I mean, people are put into positions all the time where they have absolutely no clue what they're supposed to be doing. And so I think in order to see any kind of improvement, the people that, I mean, everybody has to have the right tools in order to do a good job.
And I Julie Zink. Sorry.
Go ahead. No, go ahead.
Julie Zink in Spokane, Washington. We're about to start a very similar project here. And a question I have is, when you first went to the clinics, who did you first approach? How did you first get connected so that you could gain access to the staff?
So for this particular project, I had champions at each of the sites. So I had somebody that through the course of, you know, my prior work, I had come across somebody that was engaged in the work from the start. However, like I do this nationally for my job, and so a lot of the times it's just, you know, asking around, like who is the best person to talk to. And sometimes you go through like 3 or 4 people in order just to find the best person to talk to. Dr. Mera, who's our champion at Cherokee now, I came into contact through another person that I had spoken to at a previous conference. Somebody else I know through reminders, who builds reminders for our system. One is a friend, you know, so just like various means. But like inevitably, you know, it's not the CMO and it's not the CEO or that person. It's usually somebody lower down on the totem pole.
Thank you for that. And I have a second question. You mentioned that you used competition with the clinics. Mm-hmm. And how was that? Did the clinics like that factor? And then were there incentives or prizes for most improvement or that type of thing?
Dr. Mera, I'll have you talk to that first, since you were integrated with that process at Cherokee, and then if I have anything to add, I will afterwards.
Yes. Well, every month there's a MedExec meeting at Cherokee Nation, which gathers all the clinic directors, the clinic director from each of the outlying clinics, and then the chiefs of the departments in the Hastings Hospital. And over the month, before we started the screening with HIV chlamydia, I noticed, I sensed in the environment that there was a lot of competitions between the clinics. You know, the clinics, let's say for diabetes markers, they wanted to have the best GIPRA markers. And that I kind of learned that during the months that I would go to those meetings. So when we started the screening process, I made the mistake of not reporting the feedback in that meeting. I would report it individually to the clinics. But one day I decided, let me go to the MedExec meeting and put it in the screen, and it showed everybody's numbers, and I could just look at their faces like, oh, I can't, this guy cannot be beating me. And it was just the sheer rush of beating each other that the numbers started getting a lot better. And actually what I do every month now, I give them all their numbers. I try to be positive with everybody, even with the lousy ones, and saying, well, you did a little bit better this month. And I give a mention to the best screener for HIV, the best screener for chlamydia, and the best and the one who improved the best. Maybe you don't have the top number, but you really increased your numbers much more than everybody else from the previous month. In that scenario, I don't think we don't give any prizes, except I think it's just the sheer nature of competitiveness in human nature. Now, one thing that we have in mind, and I've discussed this with the CEO of Cherokee Nation, is that at the end of the year, every employee has a productivity bonus, and that bonus is measured in many different ways. We are thinking of including your screening rates as part of your productivity bonus. So if you're a better screener, you get a little bit more money at the end of the year than if you're not a great screener. If that's going to work or not, I'm not sure. I get the feeling it will work, but I just have to make sure that all the other tribal leaders agree with that part of the project. I'm not sure if that answered your question.
Yes, that was very helpful. Thank you.
I'm working with 2 other clinics right now that not only are sharing providers or provider teams within their system, like within their hospital or their clinic, but they're sharing it with the patients as well, so that they are accountable not only to themselves in the facility, but also to the patients that come into that facility. So they post those numbers right on a board when you're walking into the waiting room for everybody to see. Because it shouldn't be secret. You know, there's a huge gap in the healthcare that we have right now, and the healthcare that we should have. We know the best sciences. You know, we know the screening measures that should be applied, and yet we don't follow them, and we should. We should be accountable to the people that are walking into our clinic, especially moving forward when people are going to be able to, you know, in the new healthcare system, pick the clinics that they go to. They can go to an IHS facility, or they can go elsewhere as well.
Can I add something? One other thing that I didn't mention because of time constraints on the presentation is that another important factor is to provide information regarding positive results. We recently had our first 2 cases of HIV positive detected by screening only, not because the provider suspected an AIDS-defining illness. And that incites a lot of interest in screening, because they realize that people who don't have any apparent risk factors do have the diseases. And also reporting on a monthly basis the number of positive chlamydias that you have, and reporting not only that you detected, but that you treated them. That's important to because if you're not treating them, screening is purposeless. So we're starting to report how many percentage got detected, how many got treated, and now we're reporting how many came back for their reinfection test 3 months later. And I think that helps build up confidence in that the screening it's a worthwhile process. I don't think nobody disagrees with screening. It's just, with very rare exceptions. But it's just a problem of another job to do. And that's the trick that you need to find out in each individual site. How can I implement this seamlessly in the way that the physicians or providers do not have to do a lot of extra work to do it?
Exactly. It's not bad people. It's not a bad physician that's not doing the screening. It's just the result of a bad system. So change the system so that it's easier for people to screen, basically.
Hi, this is Jill Hubbard. I'm calling in from the CDC. I really wanted to thank you guys for a fabulous presentation, even though I actually couldn't see your slides. I also really want to congratulate Dr. Mera. You've got such an advantage with the Indian Health Service in that you're able to really tell who the population is, which a lot of communities aren't able to do that, to say this is my population, not just the patients who walk through my door, but who is my population and how am I impacting that. So that's really, really marvelous.
Thank you.
In my in my first life, I was an Indian Health Service physician in Tuba City on the Navajo reservation. But before coming to the CDC, I was working in quality improvement at Cincinnati Children's Hospital, and we've got a couple of publications really dealing with exactly what you're talking about. Is that next step of making sure we can't. We appreciate your challenges of trying to get pediatricians to screen and emergency departments to screen. And what we ended up, before we could ask them to screen, we needed to assure that when they tested, they could actually follow up. So we've got a couple of publications on that, kind of going over a lot of the things that you've mentioned about getting buy-in, getting a champion. Where is the system problem? Again, these are ER physicians. They're not opposed to treating women correctly. We just hadn't made it easy for them. And my colleague, after I left Cincinnati Children's, my colleague there is moving forward with trying to implement universal HIV screening and universal chlamydia and gonorrhea screening because of our high rates. In our city, the women use the emergency department as their safety net provider. So just some real great work that you're doing, and I'm not just trying to toot my horn, but I wanted to mention that we've got some work out there that for that taking that next step of assuring that you get the treatment accomplished as well.
Yes, thank you. I appreciate the comments.
Thanks, Jill. Other questions for Jessica or Dr. Mera? Comments? Well, I just want to say I am going to echo exactly what Jill said. I think this talk was really fabulous. If folks did not get the PowerPoint, please shoot me an email. I'll be happy to send it out. I'm sure it would be a benefit to you. I love the fact that, that you talked about the accountability measures with patients. I think that is critical. I think whenever there are more eyes looking, people are more able to be in their best form, if you will. And I do think the carrot is better than the stick, so hopefully the incentives will work to increase screening. Any last questions from anyone on the lines for Jessica, Leston, or Dr. Jorge Mera?
Dana, just before we get off, I'd like to thank funding for this project was through the program formerly known as the IHS STD program, but managing that program was Scott Tulloch, CDC assignee to the Indian Health Service, or he was, and without his thinking and foresight to kind of conceptualize a project like this, we wouldn't have had the ability to do that. So just thanking both the IHS STD program and CDC funding that was able to support it.
Absolutely, and thanks for saying that, Jessica. Certainly we know that the IHS National STD Program, Scott, Lori, et al. Have been fabulous and done a lot of work that has really helped all of us in numerous projects. All right, great. So Jessica, Leston, Dr. Jorge Mera, thank you so much for a great call today. We really appreciate it. We appreciate everyone being on the lines. It was really a jam-packed call. And as I always say, if you have any thoughts on a topic that you would like to talk about or hear about on a future It's Your Call, please send me an email. You guys have a great day.
Thank you. Thank you for the
invitation.
Bye.
Thank you. Please stand by.